Welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller of Johns Hopkins and consultant editor for the JOP. For this podcast, we're going to do something a little bit different and spend a few minutes highlighting some of the interesting articles and features that were in the January 2011 JOP issue. I'm going to get to that in a minute, but I first wanted to remind you that JOP is published by the American Society of Clinical Oncology. We have 6 issues a year. The goal of the JOP is to be an authoritative resource for clinical and administrative management for oncology professionals. The type of topics we cover include things like daily practice operations, health services research, quality of and access to care, regulatory issues that can impact practice, and really anything that deals with the mechanisms of oncology practice. All of our content is peer-reviewed, and full text is available on PubMed Central 4 months after publication. We encourage prospective authors who might be listening to this podcast to submit manuscripts to us online at jop.ascopubs.org. So now on to the January 2011 issue. So the lead article in our January issue is by Saul Weingart and colleagues at the Dana-Farber Cancer Institute, and it's entitled Medication Safety of 5 Oral Chemotherapies, a Proactive Risk Assessment. So the use of oral chemotherapy is an emerging area of risk in an ambulatory oncology practice. As we all know, the use of oral chemotherapy has increased greatly in recent years, and it's estimated that about 25% of oncology drugs in the pipeline are oral agents. What the authors pointed out is that few centers have safety precautions that are in place to manage or even monitor some of the hazards associated with oral chemotherapy. So what the authors did in this work was to conduct what they called a failure mode and effects analysis. And what this is a type of proactive risk assessment. And it's something that's used in industries like the aerospace industry, with the idea that you create the map of the various steps in a complex process, and you try to prospectively identify where and how each step might fail. So what Weingart and colleagues did was they looked at 5 oral oncology agents with potential toxicities. These included 6-mercaptopurine, temozolomide, capecitabine, imatinib, and an investigational agent used for gastrointestinal stromal tumors. And they looked at the whole process of prescribing, dispensing, administering, and monitoring these agents. So what they found was that most drugs had many potential points of failure. For example, for 6-mercaptopurine, they identified 23 separate points. For capecitabine, it was about 48 different points of failure or potential points of failure. In the dispensing stage, the highest number of potential points of failure was for capecitabine and for imatinib. And for the prescribing and monitoring phase, the highest number of potential failure points was for 6-mercaptopurine. They found 4 attributes that were common to all 5 drugs. First, prescription writing errors, for example, handwriting errors. Second, wrong dosage forms. Third, lack of patient adherence. And fourth, patients who did not report adverse drug reactions. So what they concluded was that there really were a surprising number of potential points of failure for each of these agents. And while this type of analysis, while useful, was very resource intensive, but it was helpful for identifying vulnerabilities in the medication chain. They made a number of recommendations, and I encourage you to look at Table 3, just to read a few of their bullet points. First, they recommended that practices dedicate follow-up appointments specifically to oral medication management. They recommended that patients be provided with images of these oral agents. They also advised that pharmacies minimize the number of dosage forms and concentrations available to minimize the dispensing errors. They recommended that patients be provided with dosing calendars similar to those provided in clinical trials, even in the non-trial setting. And they recommended to support safe home administration that nurses or nurse practitioners reach out to patients and families with follow-up calls. On the same topic, there was a companion article by Susan Gooden and colleagues entitled Safe Handling of Oral Chemotherapeutic Agents in Clinical Practice, Recommendations from an International Pharmacy Panel. And what this was, there was an expert panel of pharmacists that met over a series of 3 different roundtables, and they tried to identify best practices for handling of oral chemotherapy drugs to minimize the exposure risks. The authors pointed out that there really are few existing guidelines. They made recommendations for manufacturers and distributors, for providers, and for patients and caregivers. And in the article, there are tables for each of these groups. For patients and caregivers, they recommended that these agents not be stored in the refrigerator next to food and drink, that patients and families return unused medications to the pharmacist. They also recommended that families wash the clothes and the bed linens for patients who are receiving oral therapies and to double flush toilets. Another interesting article I wanted to highlight was about a common clinical problem, and this was entitled Evaluation of Chemotherapy-Induced Severe Myelosuppression Incidence in Obese Patients with CAP Dosing. This was by Monique Lopez-Sareo and colleagues from Texas Tech. So it's known that obese patients have increased risk of developing breast cancer, colon cancer, prostate cancer, and other malignancies. And it's also known that the prognosis associated with these malignancies is less favorable for obese patients compared with non-obese patients. Now, that may be due to unfavorable pathology, or it may be due to comorbidities. But the authors point out that another theory is that the decreased prognosis may be due to underdosing of chemotherapy. So what they looked at was a retrospective chart review of obese patients who had either lung cancer, colon cancer, or hormone-refractory prostate cancer. And they specifically compared patients who had a BMI of greater than 30 kilogram per meter squared who received chemotherapy that was capped automatically at a body surface area of 2.2, and they compared the outcomes with non-obese patients. So they actually were able to identify in their literature review about 41 patients who were in the obese cohort. Of those 41 patients, the mean actual BSA was about 2.36, even though their chemotherapy was capped at 2.2. And they compared this to the 244 non-obese patients. What they looked at specifically was the incidence of grade 3 and grade 4 myelosuppression. What they found was that obese patients had a lower incidence of any grade 3 or grade 4 chemotoxicity, including myelosuppression, although the p-value was non-significant for both. But they did identify that obese patients received significantly more cycles of chemotherapy, 6 versus 4 cycles, compared to non-obese patients. They concluded that, first, the common practice of empirically capping doses really lacks an evidence base. Second, because obese patients had less myelosuppression, there was probably room to increase doses, especially in the setting of curatively treated malignancies like early-stage colon and lung cancer. He also pointed out that due to the variation in practice, ASCO is in the process of developing evidence-based clinical practice guidelines for dosing chemotherapy in the obese population. In addition to the fundamental question of the exact dosing recommendations for patients with obesity, the ASCO guidelines will look at such things as should chemotherapy doses be modified for severe toxicities any differently in the obese versus the non-obese population, and should there be differences for different agents. The next article I want to highlight is on the topic of genetic risk clinics in the community setting. And this was a report from 2 oncologists in Albuquerque, New Mexico. The paper is entitled Ingredients for Success, a Familial Cancer Clinic in an Oncology Practice Setting. The authors are Paul Duncan and James Lynn. And they basically talked about the lessons they learned in setting up these clinics. In their model, genetic counseling was done by what they call genetic oncologists, so not nurse practitioners or certified genetic counselors. They reported that over a 10-year period of time, from 1998 through 2008, they saw 445 patients, of which 325 had breast cancer, where they typically recommended BRCA testing in about half of the patients. They found about 27% were positive for BRCA1 or 2. They also studied colon cancer and syndromes such as the Lynch syndrome or FAP. The lessons they learned were, first, that you needed to designate a specific oncologist who is willing to provide the leadership for such a program for it to be successful. They also showed that you needed to establish a clinical structure and a business plan before moving forward with something like this. They recommended that centers establish relationships with NCI-designated comprehensive cancer centers with genetics expertise for continuing education. They advised that genetic software, such as the Progeny program, be used to create pedigrees. And finally, they commented on the importance of community-wide education programs. The final original contribution I wanted to highlight was entitled Palliative Care Consultations in Patients with Cancer, a Mayo Clinic 5-year review by Arif Kamal and colleagues. So it's known that hospital-based palliative care services improve the physical and psychological symptoms of patients with advanced cancer. They also have been shown to improve caregiver well-being, emotional and spiritual support of patients, and patient-physician communication. Another frequently identified finding is that these palliative care teams can identify unrecognized symptoms and unmet patient needs not seen by the primary team. They did a retrospective analysis of all patients seen by the palliative care team at the Mayo Clinic in Rochester from January 2003 through September 2008. They were trying to understand referral patterns and patient and provider needs. What they found was that of the 1,794 total patients treated, about 47% had cancer, 21% had cardiac diagnoses, and 12% had neurologic diagnoses as the primary reason for consultation. They found that the overall volume of cancer patients increased from 113 patients consulted in 2003 up to 408 patients consulted in 2008. They also found a changing pattern of demographics over time. Cancer was about 64% of the consultations they did in 2003, but down to 38% in 2008. Not surprisingly, there was an increase in non-cancer diagnoses such as end-stage renal disease, COPD, traumatic brain injury, and so forth. They looked at two parameters. The first was the time from hospital admission until death, and they found that this had actually decreased from 2003 through 2008, from 36 days to 19 days. Another disappointing statistic was that the time from the palliative care consultation until death also decreased during the same interval from 33 days in 2003 to 11.5 days in 2008. They concluded that the delays in referrals may reflect a bias that palliative care was synonymous with hospice care or end-of-life care. They also found that even though cancer was the number one diagnosis, the minority of referrals actually came from hematology or oncology physicians. The authors identified opportunities to improve palliative care for patients by targeting education, especially for nurses, by establishing outpatient clinics, and by integrating palliative care with tumor-specific treatment in a multidisciplinary model. So I also want to mention 3 of our regular or recurring features that were in this issue of JOP. The first is what we call the GESME series, or Strategies for Career Success, which has been originated and has been lovingly co-authored by Dr. Dean Gesme for a number of years in the journal. In this issue, he and his co-author wrote about the strategic use of cancer clinical pathways. They pointed out that using clinical pathways may be a way to remain competitive in a marketplace. Pathways may allow practices to obtain incentives from payers. They also noted that an electronic health record was not always necessary for the successful use of pathways. A second feature I wanted to mention is in the section we call the business of the business. And this was a report from Terry Guidi on the Hospital Outpatient Prospective Payment System, or OPPS. This was the second of a 2-part series on practical tips. The focus of this article was on the differences between reimbursement in the office-based environment and in the hospital outpatient department, and what physicians need to know. Some of the differences include differences in coding, in requirements for physician supervision of chemotherapy, and in the use of facility fees. We're also publishing part 2 of our series of attributes of exemplary research. ASCO published a statement of exemplary attributes of clinical research in 2008, and the first part of this series covered the first 4 in the November 2010 Journal of Oncology Practice. This article by Robin Zahn and colleagues covered the 3 additional attributes: quality assurance, multidisciplinary involvement, and clinical trials awareness. This was kind of a high-level overview and also practical tips. I encourage you to look at both parts of the series and look at the ASCO document. Well, since I can hear the JOP podcast theme music in the background, I'll wind things up and remind you that JOP subscribers, which would be all ASCO members, can always access full content online at jop.ascopubs.org, and for everyone else on PubMed Central 4 months after publication. We'll be back next month when the March 2011 issue is out with another podcast interview. In the meantime, please send your comments or suggestions about these podcasts to jopeditorsdesk@asco.org or comment on iTunes. I'm still waiting for my first iTunes comment. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks for listening.